Just ask Dave, I'm sorry to interrupt.
Yes.
Can you just ask everybody who's on the call if you could please join with video? Let's pretend that we're in a room together and we can all see each other. Unless you're driving, I don't want you to get dead, but if you can, thank you so much, guys.
And you need to take attendance.
We will do that. 1 second. Second request is also to mute yourselves. Everyone who's not, and people who are not talking, please make sure you're muted so there's no background interference. So as we said, Happy New Year, everyone. This is going to be a joint meeting between, in the interest of time, a joint meeting of medical standards and REMAC. So I guess, Marie, we're going to have to do roll calls for both committees, attendance calls for both committees. So why don't we start with that, and then we'll run through the agenda.
Okay, I'm going to do medical standards first, and then REMAC, and then you can start your meeting. So medical standards attendance, please respond if you are here. Paul Barbara.
Here.
Jonathan Berkowitz.
Here.
Cindy, thanks. Cindy Basilios.
Here.
Harry Koplovich. Cindy, is Dr. Koplovich at RUMC anymore, or is he gone?
No, he left RUMC.
He is gone. Okay, so I'm going to
Yeah.
take him away as the alternate. Okay. Joseph Bove.
Here.
Thank you. Neil Samolovic. Walter Wally Carter. I'm losing it. Robert Krupe.
Here.
Great. Jeffrey Douglin. Lauren Kosterko.
Lauren was here. I saw her.
Okay,
Yeah.
well, she's got to answer, so we'll get back to her later. Reed Caldwell,
Here.
Jason Zimmerman,
Lauren must have gotten booted because she was in the waiting room. I just let her back in.
okay. So Lauren Kosterko,
Yes, sorry, I got kicked off. I'm here.
that's okay. Jonathan. Jason Zimmerman, did you ever answer? No? You got Dr. Berkowitz. David Lobel. David Eng.
Yeah, I'm here, Henry.
Was that Dr. Lobel?
Nope, Dave Eng.
Okay, great. Is Matt Friedman here?
I am. Matt Friedman is here as well.
Okay, great. Jeff Rabridge.
I'm here.
Thank you. Michael Redlener.
He can't make it today.
Okey doke. Joseph Schenker. I know you're here, Dr. Schenker.
Say it. I'm here. I just was on mute. I apologize.
Okay. Anthony Shalish. Rafael Torres. Nick Alexandru.
Hi, Marie, I'm here. Happy New Year.
Happy New Year. Glennis Seda.
Here.
Thank you. Dr. Benelli.
I'm here.
Thank you. Dr. Gonzalez.
I'm here.
Hi. Doug Isaac is not here today. Brad Kaufman.
I'm here.
Anne Marie Grigenti.
Here.
Thank you. Kevin Ward.
He should
here.
be here. I saw him on the phone. Yeah.
I'm here.
Okay, great. Grace Cacciola. Okay. Madeline Fong,
Present.
thank you. Sean Graves,
Present.
Mike Batch, Robert Ackerman,
Present.
Morty Lax, Morty's not here.
Morty's, no, he's also here. I saw him somewhere.
I'm here.
He's also.
Okay, great. Art Cooper,
Yes, I'm here.
thank you. Robert Goldstein. Khadija Langsam,
Present.
Louis Marshall, Kevin Munjal,
I'm here.
and Jessica Van Voorhees. Okay, so that is,
Oh, sorry,
medical-
that, I didn't mean, I said it silently to myself, I guess, but I'm here.
okay, thank you, Jessica. We definitely have a quorum, and now I'm going to go on to REMAC attendance. Let me open that up.
Okay, before you go on to the REMAC attendance, guys, because REMAC is statutory, everybody must answer for themselves. Please do not say, oh, I saw them here. They must answer. That is the law if we're going to do the meeting this way. So just if everybody could follow that rule. Thank you.
Okie dokies. And what am I doing? Okay. Okay, Robert Winchell. Joseph Schenker.
Here.
Whoops. Robert Ackerman.
Here.
Thank you. Nick Alexandru.
Here.
Eric Cohen. Kevin Munjal.
Present.
Cindy Basilios.
Here.
Grace Cassiola. Glenn Aceda.
Here.
Dario Gonzalez.
Here.
Bradley
Maria.
Kaufman.
Marie, it's Grace Cacciola. I'm here.
Okey doke. Thank you.
Hi, it's Brad.
Thank you, Brad. And Doug Isaacs is not present. Nathan Reisman,
I'm here.
Kevin Ward,
Here.
Anne Marie Gregenti,
Here.
Samia McEachin,
Here.
Allison Burke. Okay. Jeff Rabrich,
Here.
Reed Caldwell,
Here.
Jonathan Berkowitz,
Here.
Louis Marshall, Mike Redlener, Laura Ivacoli.
Here.
Thank you. Stuart Kessler.
Here.
Thank you. Matthew Fink. Wallace Carter. Wally Carter, unmute yourself. I know you were here before. Okay. Dominic Battinelli.
I'm here.
Thanks, Tom.
Thank you.
Efren Rendon. Peter Wire. Paul Barbara.
Here.
David Benelli.
In one of the little boxes.
Okay. Celia Quinn. Timothy Stiles. Mark Cantor.
Here.
Thank you. Sharice Berry. Joseph Bove.
Here.
Whoopsies. Sean Graves.
Present.
Matthew Harris.
I'm here. Hi.
Thank you. Robert Krupe.
Here.
Jessica Van Voorhees.
I'm here.
Arthur Cooper.
Here.
Yadidja Langsam.
Present.
Anthony Shalish. Okay. And I'm just going to do a quick count. 1, 2, 3, 4. 7, 8, 9, 10, 11, 12, 13, 14. Okay, we just made a quorum. Thank you very much. So we're all set.
Okay, very good. So let's begin. I think that the first order and item is approval of the previous the minutes of the previous meeting, which was on November 10th. Marie emailed a couple of days ago the minutes. I'll take a motion to approve.
Motion to approve.
Okay, is there a second?
Second.
Okay, and in the interest of time, is there anyone who wants to change anything in the minutes or objects to approving the minutes? Okay, so we'll look at this as the minutes were approved. Marie, do you have anything on the correspondence report?
Okay, I sent that to Dr. Schenker. Do you want to read it, Joe, or do you want me to read it?
So I was gonna, let's go through the correspondence report. This will be for both meetings. Okay, so the Office of the Council received the following correspondence. A letter of resignation from Dr. Fisher. I'd like to thank Dr. Fisher for all of his time on REMAC. He has been instrumental in helping us understand and develop psychiatric protocols and deal with issues. So we really do thank him. There were 3 resumes that were submitted. They will be reviewed by the executive committee and a nominating committee, and recommendations will be made after we speak to the candidates to the next REMAC meeting. No information from FDNY EMS, DOH, certificate suspended for 1 year, effective 12/18/20 for Christopher Foy, 341-769 from Central Square, New York. Certification suspended for 1 year, effective 12/8/20 for Hatfield Volunteer Fire Department, 0648 from Mayville, New York. Certification surrendered effective 11/24/20, Carol Delgado, 342-409 from Bronx, New York. And certification surrendered effective 11/3/20, Brian McIntyre, 382-912 from Long Beach, New York. A list of agencies submitted their protocol update completion affirmations. For those of you who did, I thank you, because I did promise the state that we would have it done on time. For those of you who didn't, please submit it as soon as possible. We sent out the following correspondence. A letter to Governor Cuomo affirming EMS personnel's COVID priority for vaccination. There was some discussion at first how EMS would be at the back end of the tier 1A group, and it was important that we felt that was something that needed to be spoken to the state. We also sent up to CMAC a New York City vaccination administration protocol. I'd like to thank specifically Dr. Isaacs, Dr. Lai, and Yoni from the fire department who did the work to put it together. It was a quite extensive and quite professionally done PowerPoint and lesson plan that was, of course, just ignored by the state. And the state felt the need that all EMS providers, even though we give IM injections every day, go through 3 to 4 hours of CDC training in order to be certified as a vaccinator. I've actually reached out to national NAMSP as well as New York NAMSP to try to find out what's done around the country, because I think that it's kind of disrespectful to paramedics who do this on a regular basis to be asked to take a 4-hour training on how not to stick yourself with a needle. We did send that letter, and we did send that training up. I apologize, but of course the meeting was canceled. I'm not really sure why, but we'll see what happens. But so that concludes the correspondence report. Are there any questions? All right, Dave, back to you.
Excellent. So let's move on to the CNC Report Committee. Paul?
All right. Thank you, David. Thank you, Joe. CNC met several times over the last month, and I want to thank the work of the group, as well as Kevin Ward, Rob Frazino, and Josh Buckland. And I want to report to the committee and the crew and everyone who's listening that we have a brand new test. It is a good test, from what I understand. It's been reviewed for all the New York State updates. Please have your providers and testers be unscared and unfettered with taking the test. It's 130 questions, and now that the updates are live and the exam is rewritten, we will reinstitute exam performance and coming to the committee with the findings of how the test is working. So essentially, we're fully past the transition phase. In the last 6 months, we really haven't tested anything that was on the updates, so there shouldn't have been any real issues with the transition. But we are all go for the 2021 protocols. The first test is going to be given, I think, January 14th. If anyone has any questions about the test, more to come.
Kevin, let me ask you, Paul and Kevin, actually. I've gotten some comments from some paramedics in the field that there's no more availability.
Yeah, I'm aware. So, right. So basically, it did take me and us a little longer to finalize the exam. So on the 2021 testing calendar that I had originally created, some of the January exams were a little earlier in January that I felt comfortable with to say that the exam was going to be done. So the first exam will be around January 14th. I'll be posting it's not that the registrations were full, it's that they haven't been posted because
Okay.
I didn't want to post until I knew there was a completed product.
I had no doubt. I was not questioning it at all.
Yeah, so those dates will be going up shortly, and people will be able to start to register again.
Great, thank you.
Any questions about the exam or the availability thereof? On another note, for anyone who's giving medical control classes, we kind of revamped the entrance process to minimize paperwork processing. And if you're going to give a medical control class, just grab me offline, and I want to go through some of the new processing that's going to streamline the cards getting back to the docs and reduce a lot of paperwork and clutter for the executive staff. So if you have planning on giving medical control class, just give me a holler. I want to tie you in with the forms and the loops and the digital processing methods we worked on. And that's it.
Excellent. Any discussion, further discussion regarding CNC? Great. Thank you for doing that work also on the online medical control course. So let's move on to the protocol committee. Dr. Lai is unable to participate today, so I'm going to go through this, and we'll do this in parts and sections. And I'm going to ask a couple of people to contribute to this discussion. So the protocol committee met since the last meeting of REMAC, of medical standards and REMAC, on November 10th. The protocol committee met 3 times on November 20th, December 4th, and December 18th. A lot of progress, a lot of work has been done. We have 2 protocols that are ready to be submitted for approval of medical standards and REMAC. And then there are a couple of 2 other items which we're gonna raise afterwards. So Paul, since you were the person in charge of revamping these protocols, why don't we discuss the 2 protocols, the sepsis protocol and the undifferentiated shock protocol? If you could please discuss
Sure.
them, present them.
Okay, let me just find them. I'm going to do a share screen if everyone's okay with that. Should I do that, David?
Did they make you a host?
Yeah, please.
Let me see. Yes, it looks like I
I
am.
thought that we can, that Joe made you a host.
Okay, good.
Yeah, I want to just make sure it's the right one. Hold on. Okay, that's the right one. Okay, so we're looking at severe sepsis and septic shock. This is a protocol for both adult and pediatrics. Is it the Zoom acceptable for everyone?
Mm-hmm. Oh, yeah,
Okay.
it's fine.
All right, so this is in the unified protocol formatting. Basically starts off with a couple of entrance criteria, asking you to avoid other reasons for shock to not be in this protocol. And then we have some objective criteria for entrance into the protocol. So presumed infection, and then any 2 of the following clinical abnormalities. And I'm going to leave this up here so we can all take a look at it. We went back and forth on a couple of ways, and we've decided to have a more loose entrance as opposed to more restrictive, so that more patients could be treated under it. I think sepsis is still under-recognized in our arena. Any questions with this?
Okay, again, I urge people who are not talking, please mute yourself because there's background noise. Thank you.
All right, so essentially these are super serious criteria with constitutional symptoms. We tried to mirror what was peds or as well as adult. These phrases like high heart rate and high respiratory rate, please understand this is a CFR also protocol as well. So this may be, we have to have it be available to all 3 levels of providers. Again, the lab values are, if you have them, we leave them in there in case someone's like being transported into a facility, et cetera. I'm going to move on to the real crux of the protocol. Essentially, CFR EMT, very simple stuff. Nothing new. Leg elevation was brought up and removed. So essentially, a glucose level for EMTs, grab paramedics. Getting into the meat, the paramedic. So we're starting off with advanced airway management as needed, cardiac monitoring, IV access to, there's offers for multiple access sites without a mandate for multiple. I mean, you can take what you need. It kind of gives you some leeway with medical decision-making. A note about PEDS IO up front. The fluid boluses is a 20 per kilo crystalloid bolus. And then you have standing order vasopressors for adult patients who remain hypotensive after the initial bolus. And it's additional vasopressors, norepi and epi. So 3 options. In the medical control options, adults can have a vasopressin drip. It's essentially a dirty vasopressin drip, simple to make. Does not require anything, any difficulties there. With PEDS, it's another fluid bolus and epi push dose or norepi drip. Okay, so just to review that, patient gets entrance criteria, supportive care, fluid bolus up front, Adults have standing order second dose fluids and 2 options of vasopressors. Medical control options for adults is vasopressin, and medical control options for pediatrics would be a second fluid bolus, push dose epi, or norepi. There are key points to refer back to the vasopressor infusion rates with regards to how we do them. I want to just hold off on the vasopressor infusions when we deal with that in the appendix. And there's a note about peri-intubation hypotension and peri-intubation arrest and the need for optimizing blood pressure prior to taking the airway. I think we could stop here. And if there's any questions on this before we go to undifferentiated shock.
Paul, there's a
David?
question in the chat from Art. It says, I do not see blood pressure criteria for pediatric patients. Is this intentional? And I guess Art and Matt, if you guys want to weigh in on what you think about that, that'd be great.
So I was part of the initial conversation. There's a couple issues, right? So one is that a manual blood pressure, especially in younger children, is difficult to obtain and is often unreliable, especially if they're screaming. You can have florally septic children with a seemingly normal blood pressure because of irritation, malplacement of the blood pressure cuff, and so forth. And also, a low blood pressure in a child is the latest possible sign, really just prior to cardiac arrest and full cardiovascular collapse. So it is much more considered standard of care to base this on signs of poor perfusion, like poor capillary refill, altered mental status, difficulty breathing, etc. So I agree with the criteria as they stand.
Okay.
Art, perfect. Art, go ahead. Art?
Yeah, can you hear me?
Yeah, we hear you.
Now we can hear you, yes.
All right, okay. Yeah, because I couldn't see the unmute by my, my little photograph thing. No, I don't disagree with the comments that have just been made. There's been quite a bit of discussion, in the pediatric community about early recognition of sepsis, and how to accomplish that, not just in the field, but also at the community hospital level. Granted that, that blood pressure is a very late sign and that one needs, an earlier sign, I think that there's been significant concern that just basing, a diagnosis of septic shock on heart rate and respiratory rate, may not be ideal. Certainly, altered mental status and poor perfusion, would potentially lead to a diagnosis of septic shock. But of course, they can occur with many other forms of shock as well. Now, the other point is, I think that we all understand that the data from the New York State Registry, both adult and pediatric, indicates that, that antibiotic administration is far more, likely to result in early effective treatment than is fluid. Not to mention the fact that most of our transports are pretty short, and getting an IV started and beginning an infusion, may consume a valuable time where the kid could be getting to the hospital sooner, to get the antibiotics as quickly as possible. Not to mention the fact that the literature extant about pre-hospital, fluid infusion suggests that it's extremely rare that that a kid would get any more than a few milliliters per kilogram, in the field. So I think this needs a little bit more discussion by protocol. I'll be happy to attend that meeting and where that will be discussed if that's considered appropriate. Thank you.
So
Can I add?
I believe this has been, just one second, Paul. I believe this has been discussed in very great detail already in the protocol committee meeting. And we have asked Matt Harris, who has also reviewed this. I don't, I don't know what is the point of bringing this back to protocol. Clearly, we all know that for pediatric patients, transport is the priority, no matter what. Rapid transport is the priority. But if the patient is already exhibiting signs of sepsis, we can try to at least initiate IV fluids. Go ahead, Paul. I
don't disagree with that.
Someone else was
David,
talking.
I don't disagree with that, but all we're saying here is high heart rate, high respiratory rate, altered mental status, and poor perfusion. Those are extremely non-specific signs, and they could refer to any other kind of shock as well, right?
Absolutely.
Right. So can I, hey, David, it's Matt. So can I respond?
Yes, guys, yes, just 1 second. Matt, I'll let you talk. Then I know that Nathan raised his
Nathan
hand
had
as
his
well,
hand,
and
yes.
Yes.
So
Okay,
I'll make this brief.
go ahead, Matt.
Oh, I'm sorry, Nate. Go ahead, Nate.
Nathan, do you want to talk first?
Oh, sorry. This is a
Nathan?
totally different point. I was just, I posted in the chat. You should take out point of care lactate because there's no reason to restrict it to point of care. You should just write lactate. If you're coming from a hospital, you might have a lactate that's not point of care.
That's a good point. That's a very good point. By the way,
Done
guys,
and done.
I'm not looking. Yeah, I'm not looking at the chat. So
I got it. I got it,
I'm
David.
focusing
David,
on
I'm watching it.
Okay. So let's go ahead to Matt Harris. Okay, Matt.
So I don't disagree at all with what Art was saying. I think that there's sort of two ways to look at this, and even at the protocols committee, I think one of the points of recognition is that this has to be accompanied by some degree of either ongoing education the next time we do broad-reaching education to the fire department, to the voluntary units. Certainly Art's point is well taken that kids who are screaming with a febrile illness will likely be tachycardic and tachypnic. I tend to think that if they're altered or they have prolonged cap refill, then those are fairly sensitive but poorly specific signs of shock. Now, whether or not they have septic shock or some other form of distributive shock, they're going to require fluids. Now, I think everyone is on the same page here that we should not delay transport to obtain IV access. I think that's a very reasonable and important point to make. So I don't disagree with Art. I think we just have to make sure that as we roll this out to our individual institutions, this has got to be accompanied by at least a brief educational moment to say, let's keep this in the clinical context, right? Lots of children have fever, lots of children are tachycardic. Use your clinical judgment with this constellation of symptoms to make a decision.
Thank you. John Berkowitz.
Thank you.
So I support kind of the pediatric assessment triangle type of methodology that I see here. I think that there's a good body of evidence to support that. I think that we're actually really looking at two sides of the same thing that we're trying to get right, which is always the bind that we're put in, which is we're trying to avoid situations where we miss early sepsis, but we're also trying to avoid situations where we overtreat things that aren't sepsis. And that's always the bind that we get into. And whenever we get into those situations, I really believe that it comes down to education, to make sure that we are educating providers enough to understand that gray zone, because that's really a gray zone of are we picking up early sepsis, but not overtreating kids who just have a febrile illness. And and personally, nothing in the protocol, at least in my opinion, will help them learn to disambiguate those situations as much as good education from EMS physicians and from providers who have it, who can speak to this. Thanks.
And I just want to bring up that this all starts with a medical decision making by the clinician that they feel the patient is septic. So unless if you have someone with other issues, they don't fit into this. This is clear cut. You feel there's an infectious process going on. When we go into undifferentiated shock, which I'd like to move to because a lot of it is similar, there is no pediatric undifferentiated shock. Okay.
Hold on just 1 second, Paul. Yeah. Is there any further discussion on the sepsis protocol? Okay. By the way, Marie, I don't know if you have Jason Zimmerman listed as attending, but he is definitely here and sending text messages.
Yeah, actually, Dr. Zimmerman and, oh gosh, somebody else. Dr. Wire is here. And Dr. Caldwell, Dr. Wallace is here.
Marshall
Awesome.
here too.
Hi, Dr.
Oh,
Marshall.
hey, Lou. Okay, good. So let's, Polly, let's proceed.
Okay, so I'm going to move on to undifferentiated shock. Just give me a minute to pop that out. Okay. All right. Are we back to screen share?
Yep.
Okay. So I would call this a little bit of a loophole protocol to help keep everyone on a level playing field. This is for situations where sepsis may not be recognized or not clear to the initial provider. The vernacular we used was this is like a doomsday protocol, essentially. The patient is crashing and we need to open up the concept of resuscitation or peri-arrest resuscitation. Protocols for patients who are persistently hypotensive or symptomatic from an unclear etiology or despite treatment from other existing protocols. So if they fall off for whatever reason from whatever they're treating, you can go into this. So clear-cut etiologies should be treated according to their other sources: trauma, cardiac dysrhythmia, sepsis, et cetera, anaphylaxis. Very similar stuff for CFR, EMT, okay? We did throw in external bleeding, even though we would hope that trauma goes to trauma, shock goes to trauma. And thank you, Ms. Williams, for catching the typo earlier. I'm going to change that there. So a lot of the same resuscitative measures for the paramedic, just getting to the medicine components. An initial bolus of 20 per kilo with standing order options for another 20 per kilo bolus after the initial, norepi infusion, epi, push dose epinephrine Q3 to 5, 10 micrograms, and then dopamine infusion. So after the initial bolus, you have 4 options under standing orders. Under medical control options, it's any of the above orders or a vasopressin drip, rapid transport, and it's the same kinds of key points. So this is for the patient who's kind of not well recognized, and it allows the patient to receive critical resuscitative measures in a time-sensitive fashion.
Okay, any discussion?
David, there are no questions in the chat right now. No hands up.
Perfect. Awesome.
Okay, I want to
Okay,
go on.
so,
I want to go to the
ahead.
vasopressor protocol, Dave. Hold on. The
I'm sorry, I
vasopressor.
thought those
I want to go to the vasopressor.
the
appendix.
Yeah, go ahead. Go ahead.
So all of this comes in corollary with the vasopressor appendix, which a lot of it is from the state. It's modified. I'm going to try and zoom out, but it essentially provides flow rates and drip rates. We feel strongly that pumps should be used, but it's something we don't think is feasible. And at the expense of withholding the medicine from the patients, we're trying to find the ways to bridge the gaps for agencies that may or may not have pumps. So there's a norepi drip table, there's a dopamine drip table, and there's a vasopressin drip table. These are Excel sheets. I have them. If you get a different type of solution, I'd be happy to change the dosing. I did a lot of 5th grade chemistry with this. So it's all legit. I'm happy to share the tables so that everyone, if you have a different supplier, so you can know the drip rates, et cetera. Okay. So that's basically it for the appendix.
Well, my question for you though is, are you suggesting that you can use this without a flow regulating device?
No, we want you using a flow regulating device. A standardized pump would be safer and better, but not everybody
Right.
has
I just
that.
want to make sure that it's not a drip rate without a flow regulating device.
No, it's absolutely with a flow regulating device, but the feedback from the field is that these devices are, if you have a pump, it's best, obviously, but this is with a flow regulating device. I'm sorry if I was a confusion there.
I believe our GOP already has a mandate to use a flow regulating device.
I think it does too. I just wanted to make sure we're all on the same page.
Yeah, we added it a few years ago when we did the sepsis and the levofed. It's in there, and Paul has it on the top of that. does label it via flow regulating device. So both your appendix and this one, well, it says it.
Yeah, actually, that's Pam's, that's Dr. Lai's doing. The protocol, the appendix actually says via flow regulating device. I closed it, so I'm not going to unshare it.
Okay, cool. Does Marty ask a question about norepi?
It says it's in there.
I was just, yeah, the flow regulating device was in there for the norepi. You're seeing it late. A couple people said it already.
Okay, good. Okay, unless there's any further discussion, I believe, Joe, I think we should probably vote on these, both for medical standards and for REMAC. So we won't, and before we move on, so we don't have to repeat ourselves.
That's fine.
Good. So why don't we do the, can we do voting? Do we have this polling thing working, Marie?
Only the host can do the polling. So that would be Joe.
Oh, Joe. Okay.
Joe would have to. Joe Ranieri, you're muted. There you go.
Joe, are you there?
Just a question. Who's allowed to vote here?
So
I'm sorry?
we're gonna do the role,
all members.
Standards would be by a polling, if we can get polling to work.
Joe, it's not going to work with polling because polling is open to everybody who's on.
Can I finish? Excuse me. I'm sorry, but hold on. Medical standards can vote via polling. REMAC has to be a roll call vote. So
No, because people who are not on medical standards, who might be here, there might be people on this meeting who are not medical standards, should not be voting in medical standards.
there you go. Everybody who's not on medical standards, don't vote for the medical standards vote. Thank you. Thank you. You did, yeah.
Okay. Someone's going to have to go through that list.
I don't know if the polling's even working. Joe, we can't hear you.
Okay,
Anyone
why
else?
don't we just do the?
We should take a poll on whether we should take a poll.
Thank you.
Who wants a vote for a poll?
Why don't we proceed? I think we'll just do this
These are just
voting.
the members.
Let's just do this voting through the chat box. Joe, you'll volunteer to count this. Joe Schenker.
Sure. Yes.
I'm
ready.
Good.
Why don't we count medical standards people, you did, yeah, and not you.
What? Start again?
I said I'm only going to count people for medical standards.
Yes. But you can't do that, by the way, for REMSCO because that's not going to be public.
No, REMSCO is going to be a roll call. REMSCO will be a roll call. You're right.
REMAC has to be a roll call vote. Correct.
Yeah. REMAC has to be a roll call vote. So do we want to do both protocols together or each one separately?
Why don't we go straight to the REMAC?
One at a time. Let's do one at a time. So
Okay, let's do one at a time.
First,
Okay, very
and
good.
then we're going to do the undifferentiated shock after.
Perfect. Okay, so let's medical standards committee. Please enter in the chat box if you're for, if you're in favor or against, and then we'll have Joe please count all this. Make sure you're sending this to everyone.
Okay. All right. So far, it is all in favor. There has not been a single no vote, and everybody's a medical standard member.
Perfect. Okay, I'll give it one more minute for everyone to get in their votes if they did not do so thus far. Good. Do you want to now do the roll call? Let's do the roll call for the sepsis protocol, Marie.
Yes, Marie, we're going to do a roll call vote for the sepsis protocol.
Okay, let me open up my voting sheet. Okay, and this is for approval of the sepsis protocol.
Yeah, I would say the sepsis protocol, and because the sepsis protocol is dependent on the appendix, the appendix can be included in this vote. And then the undifferentiated shock will be the undifferentiated shock by itself.
Okay. So this is approval of sepsis protocol and associated appendix.
Correct.
Okay, when I call your name, please let me know whether you are in favor, against, or abstaining. And this vote is only for REMAC physicians. Dr. Schenker, I'll save you for last. Nick Alexandru,
In favor, Marie.
thank you. Kevin Munjal,
In favor.
Cindy Basilios,
In favor.
Dario Gonzalez,
In favor.
thank you. Glennis Seda,
In favor.
Bradley Kaufman,
In favor.
Nathan Reisman,
In favor.
thank you. Jeff Rabrich,
In favor.
Reed Caldwell,
In favor.
Wallace Carter. Dr. Carter is driving, so he may not be able to answer me. I'll come back to him. Laura Ivacoli,
In favor.
thank you. Peter Wire,
In favor.
Paul Barbara,
In favor.
David Benelli,
Yes.
okay. Mark Cantor,
In favor.
thank you. Joseph Bove,
In favor.
Matthew Harris,
In favor.
Robert Krupe,
In favor.
Jessica Van Voorhees,
In favor.
Arthur Cooper,
Against for reasons I stated before.
okay. And I'm just going to go back to Dr. Carter in case he's able to answer. Okay. So 1, 2, 3.
Marshall votes yes.
Oh, I'm sorry, Dr. Marshall. Where the heck did I put your name?
So quickly forgotten. So quickly forgotten.
To the curb. To the curb.
To the curb.
Oh, man.
Marshall who? Marshall who?
Okay, thank you. Okay, did I miss anyone else? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19 in favor, and 1 opposed, no abstentions. The motion passes.
Awesome. Let's move on to the undifferentiated shock protocol. Let's do a quick vote for medical standards through the chat box. Joe, you'll again monitor this.
Okay.
Okay, please start voting now. This is for the undifferentiated shock protocol. Enter in the chat box if you're for or against.
And as per your digit, this is only for medical standards members, please. Thank you. Okay.
Okay, give it 1 more minute.
So far, there is no opposition.
And I'll keep my vote in for last. Okay, good. So
Just give me a second. I'm saving documents.
go ahead.
And nothing.
So
ever
everyone,
goes-
everyone is in favor on the medical standard side for the undifferentiated shock protocol.
That's correct.
Perfect. So the motion passes, and now this moves to REMAC, and now we're going to do a roll call for this protocol.
Okay, so this one is going to be. Okay, this is going to be, I'm sorry, which protocol are we voting on now?
The undifferentiated shock. That's the second protocol.
Okay, yeah, I have to label. Okay. So this is approval of undifferentiated shock. Okay. Okay, once again, I will call your name and please answer in favor, oppose, or abstain. Okay, and once again, Dr. Schenker, I'm holding you till the end. Nick Alexandru,
Yes, in favor, Marie.
Kevin Munjal,
In favor.
Cindy Basilios,
Favor.
Dario Gonzalez,
In favor.
Glennis Seda,
In favor.
Brad Kaufman,
In favor.
Nathan Reisman,
In favor.
Jeff Rabrich, Dr.
favor.
Rabrich. Okay, thank you. Reed Caldwell,
In favor.
Lewis Marshall,
In favor.
Laura Ivacoli,
Agree.
Peter Wire,
In favor.
Paul Barbara,
In favor.
David Benelli,
Affirmative.
Mark Cantor,
In favor.
Joseph Bove, Dr. Bove,
Looks like he left outer space. Oh, no, he's back.
Dr. Bove,
I was feeding the dogs. What's up? Which protocol are we up to now?
Shock protocol.
undifferentiated.
I love that protocol.
Okay,
I
it's good.
approve.
Thank you. Matthew Harris. Matthew Harris.
Yeah, sorry, I couldn't get off mute. Yes.
That's okay. Robert Krupe,
In favor.
Jessica Van Voorhees,
In favor.
Arthur Cooper, Dr. Cooper. Yeah. More dogs? No?
No, he's there. Art, we can't hear you, just. Art. You're still muted.
Sorry, in favor.
Thank you. And Dr. Schenker.
In favor.
Okay. By the way, were you in favor on the last vote?
I am, but according to the bylaws, I only have to vote if it's a tie, so.
Yes. Okay. Okay, so quick count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 13, 14, 15, 16, 17, 18, 19, 20 in favor, none opposed, none abstained. Carries.
Very good. So there were two more, thank you very much. Those are the protocols that were brought as second in motion to medical standards and now to REMAC for approval. There were two other topics that were discussed, which I'm going to ask people to help with. The first one is as a pilot program that's being brought for discussion regarding mental health response units. This was brought for discussion in the protocol committee, and it needs to be. I think it needs to be continued and discussed in medical standards and REMAC and approved by REMAC as I believe is a pilot program. And I believe that Brad has a presentation. Brad and Nathan, who have been working on this diligently, they have a presentation to present this, to discuss this.
Before Brad starts, I just want to, we've discussed this before. This does not change any of our protocols, and although it is a interesting city initiative, it does not change any of the protocols and probably does not need to be a pilot project. But I think that the fact that it's being brought here for discussion and information is great, and it is definitely helpful. But I don't believe that we need to vote on it per se.
Okay, even better. Brad, can you share that presentation? Did you give it to anyone?
Can you guys see it?
Yep.
Yes.
Perfect.
You can hear me. Up.
Just move to presentation mode, okay?
What's that?
Move to slideshow.
Move to slideshow.
Yep.
How's that?
Perfect.
All right. So I'll start, and Nathan, you can help me out whenever. Feel free to jump in whenever. So will only be a few minutes. We just put together some slides because I actually just found out in the new PowerPoint, it makes things look nice automatically, which is really makes my life much easier. So this is something we've talked about for a long time about having a mental health response unit to respond to certain EDP calls. This now is getting a new thrust from the city, including all of us, as well as H&H, and the police department and the Department of Health will start to work on this together.
Hold on, Brad. Wally, if you could mute yourself. Thank you. Everyone, if you guys can mute yourselves. Wally, Joe, both, everyone. Thank you. Go ahead, Brad.
So I think there are two major goals. And one is, the most important is to really improve the care for patients with behavioral health conditions. I put that revolving door picture because from the emergency department point of view, we have a lot of patients who come in, who get evaluated, and don't get any change in their medicine because we don't like to do that emergently, and get sent back out really with not much achieved. And that revolving door is happening in every emergency department, multiple times a day, every day. So our city, just like many other cities, have said there's got to be a better way, where we're not just taking patients to an emergency department where 5 hours later they're being discharged without really much change. The second is really to make these behavioral health responses into a medical response, where currently in New York City, they're being considered in many ways a law enforcement response. So in many cases, where the patient's not violent, doesn't have weapons, they don't need police on the scene, which sometimes can escalate a situation. They really need these medical providers. So I put in some pictures, not that you're supposed to be able to see these flow charts, but this is just to show that we're thinking through how emergency medical dispatch will decide which are the appropriate calls to assign this mental health response unit, especially staffed non-transport EMS vehicle, which is staffed with 2 EMTs and a licensed clinical social worker, will be assigned to respond to this patient. Based upon certain criteria that we control at dispatch to make sure that the patient's not violent, not an acute threat to anybody, they would selectively dispatch this unit. At the same time, there would not be a police dispatch, which is a big change. So again, EMD call type determination, I guess that's a little repetitive. So it's the plan is, and again, this is still being worked out, to be a non-transport unit, because the major goal would be to have the medical provider there, the licensed social worker, be able to check psyches and the patient's history, be able to be in touch with possibly a psychiatric telehealth provider to be able to make an appointment for the person or to make arrangements so that we don't have to transport that patient to an emergency department where many of those things are not going to happen. We're working on an intensive training program for these teams. So the plan is to have this training program, which will include the EMTs and the social workers. It will be 4 weeks long, including for the social workers, how to function in the field, and for the EMTs, more information about behavioral health emergencies. Now, they will be operating, and this is the part I think Joe was just saying, under the REMAC protocol. So there's no intention of having a different protocol for the EMTs. They'll be working under the excited delirium protocol as appropriate, or the EDP protocol. They'll be following the standard EMT assessment, which is here, which is what is taught in every EMT class in the country. They'll be doing the normal scene size up, initial assessment, focused history and physical, and ongoing assessment. Only after the EMTs follow their normal process would they look at their decision-making guidelines, which again, we're still working out, which would be basically to say, is there any potential or concern that this is a medical complaint? This isn't just a minor psychiatric emergency. And if the patient meets these criteria, which are everything you might expect in history, basic vital signs, no abnormalities on physical exam, then the EMTs would pass over the care to this licensed clinical social worker to continue really under the ET3 model. And so this really does fall under this model of changing the intervention, either allowing the care to be provided right on the scene, either by the licensed clinical social worker or with a telehealth contact, or to make arrangements for a transport to an alternate destination. Now, we currently don't have these alternate destinations, although there is the potential. You may know that there's in East Harlem, in February, the city opened a support and connection center, and that's being considered as a possible alternate destination. The goal, again, is not to have this as an ambulance transport, but to arrange through the ET3 system a different means to transport that. Again, I just put here, this is what we've already approved as our REMAC ET3 guidelines. And so everything that the city is looking at for this program is based upon what the REMAC has already approved following our flowchart. So this is trying to outline, again, I know you can't see it specifically, how these calls would end, right? So if the EMTs identify a medical issue, as they often do, the medical calls, they would treat it as a regular medical call. They would request an ambulance response. If at any point there's a danger to the crew, they would request a PD response. However, if after the EMS assessment is followed, they could pass it off. If the patient can be either treated and released at the scene, could be brought to, transported to an emergency department, or transported to an alternate destination. Now, just as Joe mentioned, I just put this in here to show that there are the Title 10 regulations for a demonstration project, which really this is not, because the EMTs would not be doing any new skills. They would not be, so really we don't think it would be a need to go under any demonstration project guidelines. So as Joe said, it was discussed at the protocol committee. Protocol committee felt there didn't need to be any protocol changes, but we did want to bring it to the REMAC to hopefully have a motion to support this initiative.
Thank you, Barry. Do you just have a timeline of when this is supposed to start? When the training is supposed to start?
Yeah, so a little bit of a surprise to us, the mayor announced that this program would be, about a month ago, announced that this would be in place in February, which, so there's been a lot of work being done over this past month. And we think at the earliest, it would probably be a little past that. So there's a big initiative to do everything, right down to hiring of the social workers, to developing, where this would function, to really go over every aspect of the program. So ideally, I think we could start training probably, hopefully at the end of February, and that might be very optimistic. Again, we would like at least 4 weeks of training for this team before it would go live.
Understood. There's a motion by Jeff Bravich that was seconded by Joe Bove.
So just for clarity, Jeff and Joe, the chat is not recorded. So if you want to make a motion and second it, it has to be verbal.
I move that REMAC write a letter of support for this program.
And I second that motion.
Thank you.
Okay, any discussion about the motion, I guess, or about this initiative?
So I just want to mention one other thing. So Again, the plan is to start in just a focused area of the city, which we don't know where it is yet, but I guess it would be probably going to be Upper Manhattan. Again, the plan would be to start in this area with 2 or 3 units, which are operating for 2 tours per day, so 16 hours per day as an initial pilot. There's a big push that all the data and quality assurance will be collected in real time. And just as we do with all of our projects, we're insisting that all of that is presented to the REMAC so that we're all aware of how this is going once it does get started.
Sounds good. Dr. Bodick, I know that you're one of the candidates that was submitted for as a psychiatrist, an ED psychiatrist. Any thoughts on this plan or anything you want to add?
So first of all, thank you for allowing me to attend the meeting before my CV was officially reviewed. I was just very curious. I was responding to the email from Dr. Fisher about volunteering. I think it's a great idea. I mean, working in the ER all the time and seeing sometimes how futile these visits are. I think any alternative to that is welcome. Obviously, the devil is in the details of how it's actually going to be implemented.
Thank you.
Good. So this motion is, I guess, medical standards can support this motion as well, but we can do, or if you would like, or Joe, would you like to do this as a REMAC?
I mean, again, I think that this is an item that probably, if we had 2 separate meetings, would have been presented to the REMAC for discussion.
I agree.
I think we can move straight to a roll call vote on the motion. And if that passes, the REMAC will draft that letter of support.
Okay.
Actually, you did. You need a roll call? Yes, you did. You nodded his head in the affirmative. So, Marie, we need a roll call to support this motion. Marie? I think
I'm here. I'm just putting together the form. Hold on one second.
No problem.
Okay. I'm sorry, this is to write a letter of support for this mental health program.
Yes, exactly.
Thank you.
So this is a motion to write a letter of support of this mental health initiative.
Okay, and it's being run by the fire department. Okay.
That's in collaboration with many others.
Okay. Okay, so once again, as I call your name, please let me know if you are in favor, against, or abstaining. Nick Alexandru,
Yes, in favor.
Kevin Munjal, Dr. Munjal.
I think he texted that he has to leave
He
at
said he had to
6.
step off. Yeah. No, he was coming back.
We have to step off for a minute.
Yeah.
Okay, I'll try and get back to him. Cindy Basilios,
In favor.
thank you. Dario Gonzalez. Dr. Gonzalez.
Sorry, I'm here.
Who?
I'm just trying to do 2 phone calls. I have an emergency meeting in my hospital, so.
Okay, who am I speaking to?
Dario Gonzalez is in favor. I don't know who this other person is.
Yeah, I don't know who the other person is.
I'm sorry, did you ask for Dr. Kessler? I may have misunderstood. I'm just trying to do two meetings at once.
No, that's fine,
Not
Dr.
yet,
Kessler.
not yet, Sue.
Not yet.
Okay, sorry.
That's okay. Okay, so Kevin Munjal is not here. It's, Bradley Kaufman,
In favor.
thank you. Nathan Reisman,
In favor.
Bradley Kaufman,
Still in favor.
okay. Jeff Rabrich,
In favor.
Reed Caldwell,
Favor.
thank you. Lewis Marshall,
Positively affirmative.
I like the enthusiasm. Wallace Carter, Stuart Kessler now,
In favor.
thank you. Peter Wire,
Approve.
thank you. Paul Barbara,
In favor.
thank you. David Benelli,
Yes.
someone's having a conversation, mute your phone. Mark Cantor,
In favor.
Joseph Bove,
In favor.
Matthew Harris, Dr. Harris.
He stepped off for a minute, he said in the chat.
Okay, thank you.
He said he'd come back.
Robert Krupe,
In favor.
Jessica Van Voorhees,
In favor.
Arthur Cooper.
In favor.
And I think we have enough votes even without 1, 2, 3, 4, 5.
Due to the momentous nature of this vote, I'm going to vote in favor, Marie.
19. Okay, so we have 19 votes in favor, and that's more than enough
So
to
we'll
give
draft
us.
that letter. Thank you, Dr.
Okay,
Kaufman.
thank you. Thank you, Brad, Nathan, and everyone who were involved in this. The second initiative that was brought for discussion at the protocol committee was the idea of leave behind pulse oximetry, which was discussed at the New York State level. And I'll ask maybe Joe or Glenn maybe to discuss this and present this to us.
I spoke to Glenn. If I could talk.
Oh, you
about
did?
it,
Okay.
if you're sick of.
Okay, go ahead.
To me. And this, I probably have less information. It's really more of an idea that certainly the fire department doesn't have specific plans right now to do. Maybe some of your agencies probably have more plans to do, but there was a suggestion to have the ability to leave behind pulse oximeters for patients that are not transported. Many of our emergency departments have the ability to discharge a patient with a pulse oximeter and specific instructions for either arranging follow-up care, being in contact with the doctor, or returning to the emergency department when the levels are low enough. Certainly, it seems like a great idea to have the EMS crews be able to leave with a patient who's not being transported a pulse oximeter, as well as instructions on the use and follow-up care and contact information. So I know there's been interest from various EMS agencies in doing this. Again, we discussed it at protocol committee. It was also discussed that it doesn't really seem like it fits into a protocol change per se, but we thought it was a great opportunity to discuss here at medical standards or REMAC or whichever.
Yeah, so just to put it in perspective, this is something that is already being done in the region. This is something that is being done by hospitals. These pulse ox monitors are made available by the state at no cost, and they would not change any of the workflow at all, meaning patients would still have to have the same process. They would still go through the same RMA process. They are going to do everything identical to what they do today. It's just in the event that they stay home, they have the opportunity to be left at home with a pulse ox to monitor themselves going forward.
I'm sorry. Yeah, thanks, guys. This makes sense also because, as Joe says, hospitals and some clinics are giving these away as well. And if the state does pull the trigger again at a later time about, pulse ox being 95% or greater, then you don't have to go. That might just reiterate for patients that, hey, my pulse ox is at 97. Maybe I don't even have to call 911 if they've already received one at home.
So this, do we have any timeline as to when these would be made available by New York State
They are already
to our
made
agencies?
available. Hospitals have received them. They are giving them out as we speak.
I know we in DER do that already. I mean, we give
Right.
out all the time.
They're available to agencies, to EMS agencies as well. So they are available today. The only, I guess, again, I think that whether REMAC supports it or more importantly, whether REMAC has a problem with it is the real question. But there are agencies doing it today. So the question is, do we feel that there's a reason to stop it or to have any issues?
And Brett, I think what came up in the protocol committee, which is true, is that a lot of people felt it's great to hand it out, but really you have to provide the supporting information, interpretation, and the follow-up for the patient. So who they can contact, or whether it's a telehealth provider or even their own provider. And I think that's kind of understood, but just worth mentioning that that's a key component of handing someone a pulse.
Dr. Schenker, I have a question.
Go ahead.
It's great that we're leaving these with patients, but I know that there are some agencies that not everybody has pulse oximeters, I don't think. Is there any way that we can get pulse oximeters?
You have to ask for them. You have to order them from the state, but the process is in place to order them from the state and give them out.
Do you know which agency within the State Department of Health?
I don't know specifically. I can find out though. I can do that.
Okay, because I'd like to get that information out to our EMS agencies.
Sure.
I see that Paul is raising his hand, and also Dr. Leviton is raising his hand. But just 1 second before that, Joe, maybe we can also get from the state if there's any documentation that comes along with this.
It does.
I think it
comes with a handout, actually.
It does. Okay, that's important because that was one of the concerns. What are the thresholds? What are the when to go to DR, when not to go to DR?
Correct.
Let's go to who was raising their hand first? Just 1 second.
I have Reed and Mark Cantor with their hands up right now, and Paul
Okay,
Barber.
so let's do Reed, and I believe that Mark Cantor and then Paul. Oh, well, also Dr. Leviton is there.
Yes.
So
just to clarify, us being in favor of this would open up the opportunity for agencies to do this in the city. It wouldn't set the requirement that agencies do this in the city, right?
Yeah, Reed, I would even suggest that think about it the other way. I think agencies are already doing this. I think that if we were opposed to it as a region, we could say that EMS shouldn't be doing it. I don't know that we have any. I mean, if you RMA somebody appropriately and you leave a pulse ox there, I don't know if we have any control over that at all. It should be through a process, and I think that it would be great if we could develop a regional process that we can give to people, or if the state already has that, use their documentation. But I don't know that we can necessarily start or stop it.
okay, a lot of questions in the chat, but again, it's hard for me to monitor the chat as well. Dr. Leviton, then Mark Cantor, then Paul Barber.
So this is great information, Joe. Thank you. And I repeat, when support Marie, if you can get us out that information, that would be wonderful. I'll send to Marie and you a document that New York City has put out for the New York City program, and maybe we can look at that as a subcommittee and see what the city's recommending to individuals, citizens who are using these pulse ox. I'll get that to you now.
That would be helpful. Thank you. Mark Cantor.
Yeah, I was going to say the same thing. The city DOH has both recommendations for providers and patient-facing materials that they've been using at least for the last 2-3 months. So Robert can send that to you. Perfect. If not, I can.
Excellent. So we don't have to reinvent the wheel. Paul.
I was
Dr.
going to say
Barber?
the same. Yeah, I was going to say the same thing. I was thinking maybe this would be an opportunity for REMAC to, my computer's freezing here, but essentially do some public service videos. I don't know if our training and education committee has it, but there might be people who do these type of YouTube stuff. It might be an opportunity for us to branch out into, getting more in touch with the public,
I know that Peter Wire also asked a question if this is only for RMAs. And I believe the answer is no, this is not only for RMAs. This is for patients in situations where we might decide that they do have COVID symptoms, but they don't need to be transported and we would leave them at home.
Well, David, the protocol, the leave behind viral protocol is not in
effect. I agree, but if it would be in effect.
If it would be in
Yes.
effect, then having a pulse ox, because that's part of the protocol, would make sense. But currently today, this is for people who would RMA from going to the hospital. So they get an assessment, they don't want to go, they have capacity, they choose to stay home, they would be left at home with a pulse ox.
Right. That was my point, that if it's going to be applied to patients who are not RMAing, then you definitely need a protocol that goes along with it, right?
No, correct. So the viral pandemic protocol does exist and has pulse ox built into it. And if we were to activate that, we'd have to develop a way to use that. But right now we're talking just about people that choose to RMA, having this extra tool at home that, like Dr. Zimmerman commented in the chat, they can buy on Amazon. So I don't think it's a bad idea.
And hopefully those patients that end up getting transported, if the hospitals are giving them away, they get it at that end.
Correct. So if they go to the hospital, they're getting it from the hospital also. Okay, so I think that this is a great discussion. There's no motion. There's nothing that needs to be voted on. I don't think anybody is opposed to it, so I think we can move forward.
Excellent. So that's the end of the protocol committee report. I'd like to move to the interfacility transfer committee. John, if you want to just say a few words. I know that Marie just sent out a poll, a doodle.
Yes.
So go ahead.
Right. So we sent out a doodle. Actually, we sent out two because the first one was the intervals weren't correct. So and I sent out a second one to hopefully get more participation, or at least to get more aligned participation. For folks who are looking at that poll, please, I put it on it, but please be aware that it's not just a single day. I'm going to use that day of the month as a recurring meeting time. So don't just look at the month, but look at it as for an availability for a recurring meeting. Once we get, the first meeting should be within the next 2 weeks. I would like to start the discussion that we have to focus on a couple of key elements. First, I want to focus on kind of formulating a needs assessment. What do we think the region needs on the interfacility side? And then looking at kind of feasibility and history. What can be done within the regulatory structure? And then what has been done in the past, both in the region and outside the region. But I'd like to start with kind of the needs assessment. So folks who are planning on attending, and I will shoot an email to everyone as well to kind of lay this out. I'd like to start with kind of traditionally a needs assessment to think about what kind of things we need to focus on, and then we can go from there. So we'll have more to report for the next REMAC meeting, and then we'll have a recurring meeting every month to kind of work through this. I also, now that I have the folks there, I have a Google group I'll set up that we'll use to have kind of an ongoing chat so that we can kind of communicate without outside of email, because otherwise I'm sure right now everyone's email box is being ridiculously cluttered, and keeping it out of email will help us. That's what I'm suggesting as a process and with the things I want to accomplish, but I'm open to thoughts from people. If anyone has any thoughts for process or kind of the aims, I'd love to hear it.
Excellent. Any discussion right now, or we can also do this offline with John after the meeting? anyone wants to add anything for the interfacility? And
Just
again,
one
I encourage, go ahead, yes.
Just one piece, if need be, the council staff can certainly support helping to set up some other means for that committee to work as well. That's a little more secure than Google.
Sure, I'm open with that. That's fine.
Perfect. I believe that REMAC has also Teams available, right?
Right.
Yeah, we could do
Office
something through
365 and
Teams and
Teams,
other
yeah.
methods. Yeah.
Yeah.
Either way, I
Perfect.
mean, I would hope that there's not going to be any PHI in these discussions, but that I would love that. I would totally take the support, Joseph, and I appreciate it.
Okay, so again, we encourage everyone who wants to participate to fill out that doodle that Marie sent out, and we look forward to hearing more. So Marie, is there any unfinished business? I don't believe so.
No, I don't believe so.
Okay, new business. I believe that Dr. Alexandra wants to bring up one new business item. And otherwise, and then we'll open the floor for any other new business.
Yeah, thanks, David. I appreciate it. I just wanted to bring something up to everyone's attention. Maybe this is something that needs to go back to protocol, but perhaps we can resolve something here tonight at least. The protocol for excited delirium, I had a call last Friday at telemetry and there was some confusion over the dose. So I cleared that up, but then when I read it clearly from top to bottom, there seems to be some misleadment in the way it's written compared to how it was in the past in our other protocol of 530. So what I wanted to say basically is that in 530, it was a protocol that said adults only. So we had it clear that this was not for children, although we have had discussions in the past about large kids that looked big and they got a full dose of Versed 10 milligrams. We had discussed a lower dose, but it never materialized for us to change the protocol, and we never did. But on this protocol, in the unified protocols, the excited delirium protocol, right on the top, next to the heading says adult and pediatrics. So that immediately, when you look at it, can be misleading because it gives the appearance that the dosing or the treatment of the patient is the same for adults and pediatrics and not different, such as in some other protocols that we have in the unified protocols, which are adult and pediatrics. And where I'm going with this is if you go down to the paramedic section, I apologize, I don't have the screen for it. Brad, perhaps you could bring it up from that slide presentation that you had. Maybe
Nick, I could pull it. Nick, I could pull it up if you guys give me a minute.
Oh, okay, great.
Is that fair? You could keep going. I'll just pull it up in the background.
Yeah, fantastic. So on the top, it says excited delirium, peds and adults. But when you go down to the paramedic section, under paramedics, the first thing, which is not really bolded or highlighted or stands out and could be easily misleading both to the paramedic and perhaps a bad dose of medication or a high dose of medication to a patient that can cause harm, is that it says the first thing on the paramedic says pre-hospital. See on the top, right on the top, it says excited delirium, adult and pediatrics. And if you go down now, if you could scroll down for me, down to paramedics and just that section right there, number 8 says pre-hospital chemical restraints procedure for adult patients only. And unless you see that or you know about it, it doesn't stand out. The next sentence after that essentially is administer midazolam 10 milligrams IM is the preferred route. So the paramedics can be misled very easily without that standing out, because on the top it says adults and pediatrics protocol. My suggestion, in order to avoid any confusion or bad outcomes or problems, at least for now anyway, would be I ask that perhaps we just change this as an emergency change for adults only, and then decide in protocol whether we want to have a pediatrics excited delirium as separately, or take this part out and just leave excited delirium as an adult protocol. Certainly as a suggestion, if we made it a separate protocol, we could always look into how we treat our seizures in pediatrics with our Versed at 0.2 milligrams per kilo, or a length-based dosing device or something like that, and we can create a better excited delirium protocol for pediatrics. But I think the way it's written here, it's confusing and misleading, and there's a potential for bad outcomes or problems.
So,
Thank you, Nick.
I think that's a great, Nick, I think that's a great point, and I think that I know that it's already 6:30 and we just finished the bulk of the medical standards work, but there's still more REMAC stuff to do. I would think that maybe we should move that to protocol and revise it a protocol rather than.
So a couple of things. So Joe, a couple of things. I think it's we should note that actually the protocol committee is going to discuss this protocol because the protocol committee is revising all the protocols and specifically the ALS portion of them, because as we know, there was a great deal of effort done in order to meet the deadline of the statewide BLS protocols. And there was a great deal of work done in order to incorporate them into the format of unified protocols. And clearly there are things that need to be changed or modified or addressed. And I think that and I know that the protocol committee discussed specifically this protocol. Nathan Reisman is working on it in the next meeting, which is going to be not this coming Friday, the Friday after that. So I think that kind of goes in line with what Joe Schenker just said. There were a couple of suggestions that were brought up in the chat group. For instance, Jeff Rabich suggested to put this to put it in bold letters. I'll open up the discussion. I know that Pesach, you wanted to say a word, but again, we're going to try to move this forward to the protocol committee if unless anyone has anything burning to contribute to this. These are all valid concerns and valid points, Nick, and they are going to be addressed in the upcoming Friday meeting.
Well, my only suggestion here would be it'll be evaluated, and that's fine. I'm okay with that. But in the immediate time frame, that's another 2 weeks. Plus, when it comes back to REMAC, I mean, there's a potential out there for almost 2 months worth of.
How about a REMAC advisory or a message sent out drawing attention to that until a protocol can revise it? At least a warning.
Yeah, something to the effect. That's why I suggested maybe an emergency change now, just for adults only, and then it can be refined at protocol when it's discussed there.
Nick, I don't think that's that easy to change this for adults only, because the New York State BLS protocol is for adults and pediatrics. So that makes it a problem if we want to try to keep the unified protocols as as close to the New York State BLS protocols, the format and the titles. So I think that this protocol has been taught and went over, and I think that this is more than anything, this might be just a training issue that people need to be aware of this. But I think that maybe Jeff's idea to highlight it for adults only would be a good quick fix for this. And maybe we can even do that, Marie, right now. I mean, this is just a typo, right? This is just a correction. That's not a big deal. If we just bold it and underline it.
We can, that's an easy fix. And I could send out a REMAC advisory just to alert people that, we've noticed that people are unclear and this is the clarification. So that can be done.
The way it looks like here, anything for pediatrics would be a medical control option. There is no order, essentially no medical management for pediatrics.
Of course.
The way it's written here, it's easily confused.
We should definitely go talk about pediatric dosing, and I'd love to see all pediatric all dosing weight-based with upper limits, etc. Paul is shaking his head, and I think that is part of the work of a protocol committee. It's beyond the scope of this discussion right here, right now. But Marie, if you can make that, do we need to vote on this? Just highlight the protocol and send out an advisory
to make
the executive. Let the executive committee decide it.
Yeah, it's not really a protocol change.
Guys, to make it bold is a typographical thing that does not need to go through a committee.
Perfect.
If we vote on it, it then has to go to CMAC before we can make a change. So I would suggest that we just bold it We can just send out an advisory that lets people be aware of that, and then discuss the protocol at the next protocol committee to discuss the content of it.
Yep, that's a clerical change.
Correct.
I'm fine with that. I just want to have the questions out for everybody so we don't have problems.
And it,
Perfect.
So Marie, that's in section 8, the part in parentheses should be bolded and underlined. Okay? That says for adults only.
All right, Pesach, you have a question, and then we're going to move on to the last part of REMAC.
Yeah, I was just going to suggest making it red, bold, and caps and putting it at the beginning of the line like we have in other protocols. And I think that was just an oversight probably on my end when we originally put it through. And I volunteered to make that change for Marie.
Even better. Okay, I think that concludes the medical standards part, and we can move on to REMAC.
There's really
Go
not
ahead,
much
Joe.
more. I just want to continue. I mean, basically, the executive committee did not meet, and we just had the medical standards committee meeting, report and meeting. So let's move right to the QA committee report. Joe Ranieri, there you are, if you don't mind.
Thank you very much. So I'm actually going to do a share screen. And I'll just pull up the minutes. All right, so the last meeting of the QA committee was on December 1st. We went through we have one regional restriction case that we are currently investigating and gathering more information on. We are working with the folks at First Watch to continue to refine the accuracy of the regional dashboard that's been developed for the STEMI and stroke QA measurements. And we are still waiting for integration with telemetry data as well, which will further add to the data that and the insights that First Watch will provide. We finalized a after action report related to the surge of the COVID cases. That report was sent out by Marie yesterday. I did pull together a summary document, which I would like to actually review with the committee. I'll do that once I wrap up given the full report. And then the committee is looking at replacing some seats for some members that have not been attended. The meeting was adjourned at 16:05. We had originally decided to meet today, but due to the scheduling the REMAC meeting, that meeting has been postponed. The next REMAC meeting will be, next meeting of the QA committee will be the first week of February. So as stated as I just stated in the minutes, the QA committee pulled together a after action report related to COVID response. So while the report, Marie sent it out yesterday, it's fairly extensive. We did want to highlight some of the challenges and recommendations that came out of that, many of which are things that the region is working on various levels. But we wanted to touch upon them as there are some items in here that the REMAC should consider maybe pulling together a tag on as we are in the midst now of increasing cases here in the city, and maybe make some decisions or pre-make some decisions ahead of time before we get into the thick of the response again. Hopefully that does not happen. But some of the challenges that we saw was that obviously the rapid spread of COVID-19 created a sharp increase in EMS call volume that quickly overwhelmed the system. With that, we also saw a massive increase in out-of-hospital cardiac arrests, which prompted the quick initiation of various cardiac arrest protocols. And then there were a number of difficulties in terms of meeting staffing needs. So some of the recommendations that came out of that report was to look at leveraging hospital data, hospital surveillance data to help give us like act as an early warning system. As we saw COVID cases increased in hospital first before we saw it reflect in pre-hospital call volume. One of the big ones for this committee to look at is the development of triggers for implementation of modified staffing standards, as opposed to making some of those decisions ad hoc. Working with the State Department of Health to give continued priority access for COVID-19 testing as well as vaccination, which is currently in progress. Obviously, we had the vaccine rollout these past couple of weeks, and the REMSCO held a couple of pod events just after Christmas. We're still working with City DOH on that. So in addition to the staffing standards, also for identifying certain crisis standards of care, such as the cardiac arrest protocol, the modified arrest protocol, and looking at triggers for those and kind of using the experience that we had to identify certain other maybe disaster standards of care protocols that the REMAC may want to be able to quickly implement. So some of the logistics challenges were related to PPE. One of the things that was set up from that is the REMSCO is now a pod for PPE distribution, and we are partnered with City OEM and City Health to ensure that EMS services are able to get PPE when they need it. One of the recommendations that came out of that was for the REMSCO to facilitate a PPE exchange forum. So this was in particular to N95s, where you have different models and you have to do fit testing for them. And when we were doing our pod, we distributed about 5 different brands of N95s over the course of a month. So obviously that required a lot of refit testing of providers. But if you're able to swap those models, you can kind of stay consistent within your own agency. Another recommendation was the development of a group purchasing agreement to increase buying power for EMS within the region. So some other challenges were related to mutual aid, including looking at early warning triggers for activation. One of the big challenges was the private ambulance resources were not able to be mobilized into regional mutual aid without a special exemption being made to the national ambulance contract. So normally with the NAC, you're only supposed to be pulling resources from outside of the region, and our regional mutual aid system did not provide financial security to facilitate inclusion of the private ambulance resources within the regional mutual aid request. So the idea was so one of the recommendations is to create a mirror model of the NAC contract, but on a New York City basis, which would allow the city to, upon activation of this regional contract, to allow private ambulance resources to participate within 911 response, or if there's a lot of interfacility work that needs to be done, similar to what we saw during Sandy, that this way the financial mechanisms are there to facilitate that. Currently, our mutual aid system basically has those private ambulance resources that participate in 911, and they're expected to bill for the transports to recoup their costs, which obviously is not always a known factor. One of the challenges with that was that when we utilized the NAC, you had a lot of out-of-state resources that were not familiar with the city, not familiar with hospital designations, and not familiar with our protocols transporting patients. It limited the types of the call types that these ambulances could be designated to. By increased usage of private ambulance resources from within the region, those providers know the city, they know the protocols, and that would grant more flexibility for those mutual aid units to be dispatched to higher priority calls to further support the system. So some of the other regional challenges were related to regulatory challenges. So we saw 16 significant COVID-19 policies released from state Bureau of EMS and from the REMAC between March 1st and April 30th. That made it very difficult for agencies to implement and keep track of. And so at some point you had providers using different protocols at different times. They were unsure which protocols were in effect at which time. That goes back to developing the triggers that we discussed earlier. There was a huge mental health aspect of this as well. And while the study only briefly touched on it, we're going to be doing a more in-depth look at, for the region, what the mental health needs are for EMS. So that's a brief overview of the AAR. I encourage all of the committee to read the full report. And with that, I will hand it back to the chair to continue with the meeting.
Thank you very much. Any questions about that report? I think that, it was very well put together. Joe did a lot of work on this, and I thank him for that, as well as the committee. The plan, or the hope, was that we could get this after action report into an EMS journal like GEMS or EMS World, to make others aware of what's going on and aware of what our experience was, and hopefully help them better prepare for the future. I think that would require a seconded motion from the committee for us to find a venue to submit this document to for publication. So I ask if anybody is interested, if anybody feels that that's appropriate, if I can get a motion and then a second, that would be great. I can't make the motion. All right. Well, hearing none, then I guess
I would make the motion. All right, it's Brett, sorry.
that's fine. Thank you. So I guess a motion to reach out to publish this document in a journal such as GEMS or EMS World.
Art Cooper, second.
Great.
Yeah, I second as well.
Any other discussion on that? I mean, I think Joe presented it very well. And I really think that this would be a tool that somebody else could use.
Yeah, I'm sorry, I wasn't aware that we needed permission to do that, because we've actually already started investigating that.
I think that we just need support from the region. If the REMAC is going to agree to do that, I think that the REMAC has to support that decision. I know that we've talked about it at the executive committee, we've talked about it at QA, but it should require, or should have support from this entire committee, so that things are happening transparently. So
Joe?
Yeah.
This is a dumb question, but since a lot of people here are affiliated with academic institutions, any reason this needs an IRB approval?
So there's nothing in it that is, this is all information, and none of it is research. There was no retrospective. It's just an analysis of the event. It was not, there's no data collection or anything.
It's a process analysis.
Correct.
Okay.
Yes. Okay, hearing none and having a seconded motion, are you okay with a roll call or a Zoom for this, or it has to be a roll call? You're muted, did you? I'm asking your opinion.
Why don't you ask if anyone objects? If no one objects, then you can do it by acclamation.
There we go. Does anyone object to us submitting this for publication? All right, hearing no objection, seeing no objection, we will move forward. Thank you all. Okay, next would be training and education. Mr. Lax, wherever you are.
I am here. So training and ed did not meet in December as we anticipated that we would, but we will hopefully meet before the end of this month. I'd like to get that done before council, so we'll have a little bit of information to report. We want to do somewhat of an after action on the training that was done online. I can report that the numbers that we have, I've been monitoring the data for the combined numbers for the DOH training. The DOH training itself is 6,771 people. That's a combination of those that did the long and the short version. Only 977 did the short version, which indicates that a large majority of those that did it had done it already in 2019, which is a good thing. The New York City training that was done between medics and EMTs is currently at around 4,440. So those are the numbers to date, and we hope to do again some sort of after action and see what we can do better next time.
Great, thank you. Okay,
By the way, a quick thank you to the regional council team that facilitated the vaccinations for the volunteers and the private commercial agencies. Thank you.
Thank you. All right, RTAC report. Is there anybody that can report on the last RTAC meeting? Or was there not one? Usually Doug reports. I know he's not available.
I'm not sure if there was another RTAC meeting.
So we'll move on.
Joe, I'm pretty sure, this is Art Cooper. I'm pretty sure there was not.
Correct. Thank you. Regional council update. You did you?
I have to quick check in to it's only 15-minute drive. Do you want me to let them first?
Whatever you want.
Get a key.
Okay. Did you? Was there a regional?
REMSCO last met November 17th. The ambulance tag will be discussing a possible regional policy regarding safety of wheelchairs and other equipment for disabled patients, use of Uber and other accessor riders being considered. And the tag members are Dr. Leviton, David Mitkansky, Brian Levinsky, and Robert Bristol. We already know that COVID vaccination pods are being planned, and I can tell you that one of them went off at least well because I got my shot. Mental health training has begun. There are still no REMSCO contracts executed by New York State DOH. This is very concerning. The Glen Oaks VAC expansion CON was approved, and BLS NAOS update training is posted. And as Dr. Schenker said before, we had promised to get everything done by January 1st. I wonder how close we got, but because now it's January 5th. But that basically is the REMSCO report.
Thank you. Any questions for Dr. Langsom? Seeing none, seeing no hands up, we'll move on. There was no CMAC report. CMAC last minute canceled their meeting at which our vaccine training was supposed to be presented and wasn't. So I just had to say that one more time. But there was no meeting. I guess we'll wait for the next meeting.
Yeah, Joe, this is Lou.
Yes, Lou.
Yes, and there was no meeting, and because they changed the dates, all the documents that we sent up for the last canceled meeting have to be reapproved for the next meeting. So I'm waiting for them to reapprove all the documents we sent up before so we can release stuff.
Great, thank you. Okay, next under unfinished business, really, because it's not new business anymore. We are back on the bylaws. We have, I'm going to put them up, but basically we are back to our first reading because we made changes at the last meeting. I'm not going to read them word for word. I will, however, just discuss the changes that were made. Give me 1 second. Okay. All right. So we are up. We're sharing. The significant changes that were made are highlighted in red right over here. The language qualifying the chairperson of medical standards as a municipal FDNY EMS person and the vice chairman as a, or vice chairperson, I'm sorry, as a non-municipal person were removed. And the Medical Society of the State of New York physician, the the non-EM classification was removed at the behest and as at the request of Dr. Wire. And I think those are both reasonable changes. There were no other changes. That is the change that was made. Does anybody have any questions in terms of this draft? I would read it again, but I would kill myself. So I'm going to not do that. Any questions? Okay, being that these changes were made, we do need to review it again at the next 2 meetings before we can vote on it. So that's where we stand right now with our bylaws. If nobody has any questions about it, I will stop sharing it. Any questions? Anybody make any comments about the bylaws?
Did you send this out? What the only change was that you took away one of the seats that was designated for a fire department physician?
No, we did not take away any seats designated for anybody. What we removed was the classification that the chairperson had to, of medical standards, had to be a municipal FDNY EMS physician, and that the vice chairperson was a non-municipal person. That language was removed. The seats remain the same.
Well,
So-
practically that removes one of the seats that were designated for FDNY, it looks like.
Well, it removes, I mean, I guess, yes. I mean, it could be that that both of these seats would be non-FDNY seats. That is correct.
Hmm.
The other option would be to remove the chairperson and vice chairperson and have under medical standards committee, a municipal FDNY EMS seat and a non-municipal seat.
But Joe, why can't they both be fire department?
Well, they're not, meaning.
They can be.
They can be, that's true. They both can.
Right, but previously one was specifically for, an FDNY or municipal.
No, but Joe, I like your idea. Your idea actually. You make the representatives from medical standards, make them one FDNY representative and one non-FDNY representative.
Well, municipal FDNY, meaning somebody,
Yeah,
if
yeah.
an NYPD physician were to be the chair, that would satisfy that requirement.
Well, don't call it
rare that
chair.
That would happen.
Yeah.
And we can specifically say FDNY, but I think that the way it's worded, it could be either way. I just want to be clear about that. Again, I have no problem changing it the other way. It would be at the chair's discretion who the two members would be. But that we could do that. It's again, this was the recommendation at the last meeting, and that's why it was changed to be this. We can make this change now, and then this could be the first reading, and we would still have 2 more readings with the change if everybody agreed on that.
Yeah, I think we should do that.
Make a motion to do that. Yeah.
We'd have to have a second.
And you can second it, Nathan.
Okay, what are we doing now? Because I'm confused.
There's no, so under number 16, Marie, instead of medical standards committee being chairperson and vice chairperson, it will be municipal, FDNY EMS, and non-municipal. So
Just like in 15.
change.
Just like in 15.
Right, just like in 15.
Correct.
Okay.
That works, Joe.
Can I make a suggestion?
Yes, go ahead.
Can we remove the specific agency and just say municipal? We have no other referral to a specific agency or what uniform you wear anywhere in these documents.
Well, that's not true because the seats in this document are actually very specifically done by agencies and not necessarily just.
Okay, then I'm wrong. Okay.
If you look, I mean, the first section is over here is FDNY, and then Greater New York, and then the Downstate Ambulance Association and the Volunteer Ambulance Association. I don't think it's inappropriate to have municipal FDNY and non-municipal instead of chair and vice chair, and it would be at the discretion of the chair to assign those seats.
And do we put that somewhere also? Do we write that it's at the discretion of the chair to assign those seats? Do we put that in the wording somewhere below or on top?
Well, yeah, I guess we should then. That would be the way to clarify that.
Oh, boy.
So it would be over here. We'd have to add a section right here in the appointment process saying for the purpose of nominating a representative from the Medical Standards Committee, the chair will appoint a municipal FDNY representative and a non-municipal representative. It would be in this section here. I mean, I could write that language. It's not here right this second. I mean, would you answer this? If I write that language here, can this be the first reading or do we have to wait till next time?
No, it could be the first reading, but I do have a question.
Yes,
If you go back to where you have before, unless I'm misreading it, the line 16 says that you want the chairperson, the vice chairperson to be the representative. You remove those words, then it may be just anybody. Now, if that's what you mean, I don't care. But I mean, I think
exactly.
I thought you originally wanted it to be the chairperson and the vice chairperson to be the people. Forget about where they come from, but you want.
What you're suggesting is that the the chairperson be an FDNY EMS person, is what you're suggesting.
I don't care who the chairperson is, who the vice chairperson is, but you do, I thought you wanted that the chairperson and the vice chairperson be on this committee.
That could be the case, but I would say that if you want to,
Well, maybe you don't. Maybe you want anybody from medical standards to be on this committee. Why
don't you leave that? But Yedidia, why don't you leave that for the decision of the chairperson of the medical standards committee? If he wants to be on the committee, then he'll put himself as one of those two. You know, let the chairperson decide that.
Maybe if that's what you want. I don't know if that's a good idea. I can see both sides. You may want the vice chair to be a member, whether they want to be or not, or you may want to say, I don't really need a chairperson of medical standards. I can have anybody from medical standards. I don't care how you do it, but it does make a difference. You're right.
Well, Joe, you can, I mean, Yedida, you can, there are a lot of people on medical standards, which I think could give the report to REMAC.
That's fine. I'm not taking, David, I'm not taking a side. Depending on what you write here makes a difference.
I think you did just is making a clarification for everybody to understand. I personally don't see it as a difference. If the purpose here is to have a municipal representative and a non-municipal representative from the Medical Standards Committee, then the red section should be the primary part of this A and B, and it should be at the discretion of the chair who those two people are. If the purpose of this line is to have the chairperson and the vice chairperson of the Medical Standards Committee sit on REMAC, then the language, the way it's written, is the correct language.
Historically, that's correct. We should probably go back to the original language.
David, if you don't leave, if it's not left the way it is, it could be very good chance that even though you're the chair of medical standards, you wouldn't be on REMAC.
Well,
I don't know if that's a good idea that the chair of medical standards shouldn't be automatically on REMAC, since the chair of medical standards is the one who has to report to the REMAC. So if you take off the requirement that it be the chair and the vice chair, it's very possible that Dr. David Benelli would not be on REMAC, and there would not be anyone, the chair of medical standards wouldn't report to REMAC. I don't care what you do. I just know there's a significant difference.
I don't know if there's that much of a difference, because the chair of medical standards will appoint someone who will report to REMAC. I don't see any, it's not much of a difference.
That's your decision. I
have a question for that. If the chair of the medical standards is a doc, do they get a vote on the REMAC?
They do. The chair of medical standards is a doctor. These are both voting positions.
But not all. But if you make it so that a non-chairperson is able to represent the medical standards, because then they could assign a non-doc as the representative.
That's a good point. So that's a good point. We should write physician, municipal, FDNY/MS, and physician, non-municipal. It's a voting seat. It has to be a physician. Yeah.
Meaning the position is voting. Whether but Joe is suggesting is that the proper way to do this is to have a municipal and a non-municipal, because the chair theoretically could be a non-physician, in which they would not be able to represent the Medical Standards Committee on REMAC.
Well, you could give the report, but they wouldn't be able to vote.
Correct. So the voting seat is a physician representative.
Or you could stipulate that the chair must designate a physician representative to represent medical standards at REMAC.
So I guess what Joe is suggesting is that instead of it being the way it's written right now, it should be municipal, FDNY, EMS physician, and non-municipal physician.
Makes sense.
Appointed by the chair of medical standards.
That would go lower, yes. The appointment part is down here, but the line here, the language that would need to be corrected would be municipal, FDNY, EMS physician, and non-municipal physician. And then down here under the appointment process, there would be another line that would say appointments from the Medical Standards Committee shall be made by the chair for a municipal EMS a municipal FDNY physician and non-municipal physician. So that the appointment, it's clear that the appointment is by the chair to this committee. That would be how you would do it. And I think Joe makes a very good point that the chair of REMAC of medical standards does not need to be a physician, and therefore the right way to do it is the way Joe suggested. Meaning,
Okay, we vote. Do we vote on this?
Could still give, well, we have to vote on the change. No, we don't have to vote on the change. We have to agree on the change, and then we have to read it 3 times and vote on the draft. So what we can do is we can make the stipulation that we're going to make the following changes. Under this A, it will be municipal FDNY EMS physician. Under 16B, it will be non-municipal physician. And the language that will be added under the appointment process will read, appointments from the Medical Standards Committee of REMAC will be made by the Medical Standards Chair and shall include and shall be forwarded the nominations to the Regional EMS Council for approval. So that would be the language that would be under the appointment process. I'm looking at a PDF right now, but that would be the change that would be made that would go to a second reading at the next meeting. If we all can agree on that, if everybody's comfortable with that, I'm willing to say okay, and let's move forward.
Second.
Right here.
Excuse me, but we have medical standards bylaws. And so I don't think you can just say that the chairperson and vice chair are not physicians. I need to look at the bylaws.
I'm not saying that at all. I'm saying that the appointment from medical standards to REMAC, we're not even talking about the bylaws for medical standards. If the bylaws for medical standards say that a physician has to chair the committee, that's great. What I'm saying is that the appointment from medical standards to REMAC is made by the chair and must include a municipal physician and a non-municipal physician. That's all we're saying. And that change we can make without looking at anything else. All right. Does anybody have any comments or questions about that?
Are we done?
I never activated this card.
I don't know what that
All right.
was.
So hearing no change, no comments on that, I think we will go ahead and make those changes. Marie, I'll send you the exact language to be added.
Okey doke.
And we can entertain a motion to, unless is there any new business?
No.
Anybody else have new business? Hearing none, I will entertain a motion to adjourn.
Move to adjourn.
Motion to adjourn.
Thank you.
Thank you, everybody. Have a great day.
Thanks, everybody.
One.
Be safe, everyone.